So very good evening. We'll come back to the second part of maternal medicine in MRCP. As I told last time also, let me tell you again. This maternal medicine, basically, few questions are come from the maternal medicine. Basically, this is a part one topic, but there are some questions also will come part two. You will find out that there are questions are coming in different sections like cardiology, neurology, ID, which is related to the maternal medicine, and they come in any section of the uh, questions, but they are related to the maternal medicine topic, and you will be able to answer it if you know the core concepts. Before I would start, I would like to tell you that I was asked to take some of the recap classes for last week, so I will go through few of the topics which will seems to be repetition for some of you, but this is what because of some technical glitches I was told to do that. And before I proceed to the next slide, I would like to request to all of you that please raise your hand or send some questions in the chat box what you want to ask, because if in between you stop it, that will be difficult. And the most important topic and questions is that this class is based on basically Royal College guidelines to write Royal College exam. If don't get confused with the Southern Asia or subcontinental or to specific India or particular state guidelines, this will only not only complicate you, but also it is also make you difficult to answer in the exams. So, and most important thing, we will be not able to discuss that much detail in the physiology of each topic because that's beyond the scope of this class. But if you have any questions, you put it back. I will jot down and try to answer today last, or maybe I will do in the next classes. In between, if you have a question, please do let me know. Without taking much space time, we'll move it to the next slides. And with that, why pregnancy is so different, all of you, as I discussed in the last time, there will be changes in the body from all aspects, from the respiratory, from brain to thyroid to GI to cardiovascular to renal to hormone and hematological. And this is why, keep it in back, we will have to start the next sessions. So give me a moment. So if you're able to see the questions, we'll start with the question. So this 30 years old lady pregnant with unilateral leg swelling with a pain and with the Doppler shows a DVT. What is the next step of management? How do you do that? So usually we have to start a anticoagulant without investigating further. Next question. Similarly, this 24 years old lady which is having a suspected pulmonary embolism, after discussing with the patients and patient's family, we wanted to do scan. Which one used to do, CTPA or VQ scan? So the answer should be there that CTPA has to be done, and it has a more maternal breast cancer risk. Now, if you understand these questions, we will move it to that why pregnancy and DVT is little different. First of all, if you go through the list of in the well score, you understand that this pregnancy one of the risk factor for having DVT. That because pregnancy is a hypercoagulable state and basically everything happen in the last trimester. What is the pathophysiology to have that? Because there is increased factor of factor 8, factor 7, factor 10 and fibrinogen, and decrease of protein S. This is the main reason for having the more prone patients develop for DVT. And also there is uterus, which is caused the compression of the gravity uterus in the inferior vena cava, which is caused the venous status. If you clearly remember the virtuous triad, all those things can cause prone to having patients DVT. And how do you manage it? Warfarin is contraindicated. You have to go for small molecule, subcutaneous low molecular heparin, which is preferred over the IV heparin because of the less bleeding and the thrombocytopenia. Basically, it can less chance of hit. These questions are predominantly asked in part 1, but questions can sometimes come in the part 2 also. Let's see more precisely that what all the investigation you have to do. As I told you previously, we are not going to each and every detail. Basically exam focused class. So you have to know that what all has to be done clearly. So you will get the questions like this: when you are suspected a DVT, what your supposed investigation you supposed to do? First, you have to do the compression duplex ultrasound should be taken if there is a clinical suspicion of DVT. And how do you suspect the clinical suspicion? You have to go for the well scored for the DVT. Please keep it in mind. All the patients which were suspected pulmonary embolism has to be done ECG and chest X-ray. Please remember, this is a very statement that we always consider mother is our patient. The kid which is yet to born or still unborn is not our patient. So our primary goal of safety is look like a chest X. Do the take care of the mother. For that, keeping in mind, doing chest X-ray may be theoretical harmful for the baby, but we have to get it done. And this is remain correct in the real life as well as this remain correct in the exams also. Now, if you have a patient who are having symptoms of DVT, you can first do the lower limb Doppler or compression ultrasound, which is showing confirm the DVT. Then you don't have to do any more investigation and proceed for the pulmonary embolism or DVT screening. If the patient suspected, like a patient having hypotension, tachycardia, RV strain kind of feature in ECG, all those features, if you there you find out and your well score is matching based on the pregnancy being the one of the cause factor, you see the lower limb Doppler, you can proceed for the treatment of pulmonary embolism. No more investigation done. Please remember these points very carefully. If your lower limb Doppler showing DVT, you don't have to do CTPA or VQ if your pulmonary embolism suspicion is quite high. The exam has been tricked multiple times, in particular in part 1 on these lines, and it has been taken. Now, whether you have to prove CTPA or VQ mismatch, it has to be done in the local protocol as well as discussing with the patients as well as the radiologist. So in NHS is very clear in one part, you have to discuss everything or anything to the patients in detail, the language which he or she understand. You have to convey all the risk factors, even if the chances are less than 1%, you have to convey to them. And this is the main motto of NHS taking this exam, to make you aware of that you have to tell these things to the patients. Now, whether you to do CTPA, yes, CTPA being a more specific, if the patient's kidney function is being normal, you can do CTPA, but you remember you have to explain that there is a little bit lifetime risk of breast cancer because the breast tissue being very sensitive during pregnancy has more particularly effect of the radiation can be prone to them for having more signs of breast cancer. Now, move to the next, whether we have to do the VQ scanning or not. This also has to be discussed with the patient's family and the patient, that this increase the theoretical risk of childhood cancer compared to CTPA. So if the patient's going to take CTPA or VQ mismatch, this based on these points, you have to explain to the patient family. And this has been multiple times asked in questions, that what to explain in different forms. So to please remember these points. And they will try to trick you that whether D dimer has any value. Please remember. Yes. Yes. Yeah. Please remember the D dimer has no value in the patient pregnancy with suspected thromboembolism. Now, keeping in back of your mind, this is gone for the DVT. I would also like you to empathize few more points, which is very important when you are treating a patients or getting. There are always. Yes.
Sir, excuse me. Sir, what's the well score? Well score to diagnose the DVT in pregnancy. The scoring system.
There are no the well score. There is no separate well score for particularly diagnosis for DVT. The well score which you normally develop, I'm sure you have taken cardiology class and where you got the different component of the well score. It's remained like a all the components is there, but the pregnancy and hypercoagulable is the one of the part of the well score. There is no separate entity for DVT for well scoring, particularly for pregnancy. But there are
Okay, sir.
two types of well score, one for the pregnancy, one for the pulmonary embolism. That you have to remember the components only. Okay. Okay.
Okay, okay, sir.
Yeah, no
Thank you, sir.
problem. Yeah, sure. So now keeping that, you see, there are a lot of other things that I'm not put in detail that how to thrombolize, what all the topic to be giving in thrombolize, if the patient pregnancy, because these are not very much common in asking exam questions. The other criteria remain almost same in DVT, but these are the particularly which is much more differ from in pregnant lady who is getting a DVT and pulmonary embolism. In aspect of your level in exam to clear Royal College exams. Now, when you are going to get the, am I audible now?
Yes, sir. Yes, sir.
Yes, sir.
Okay, okay.
Your speaker was muted.
I don't know. Somebody got muted. Okay. So as I was telling that, like how you get the NHS like DVLA, you will also get sometime like how this when to give fitness to fly. So we will see each and disease, including the pregnancy. The question has been multiple times asked. So when you get a patient with, suppose it's a cardiovascular, you have an unstable angina or uncontrolled hypertension or uncontrolled cardiac arrhythmias or decompensated heart failure or severe symptomatic valvular heart disease, they are advised not to fly. It's a, their guidelines are very clear, and if you are working as a registrar or specialist registrar in NHS, this kind of patients will frequently come to you, and you have to be certified that. So it is not only important if you're going to practice in UK to how to practice, how to prescribe it or practice it there. It is also exam oriented questions also. Next is that if you have an uncomplicated myocardial infarction, the usually time to 7 to 10 days. If you have a complicated myocardial infarction, the time is 4 to 6 weeks. Please remember all the values. This is unfortunately part of the questions where you have no other part other than have to use your brain to mug it up and get. The artificial intelligence won't help you here. So next question is that if you have a coronary artery bypass grafting, you have to do it almost 2 weeks, 10 to 14 days to keep 10 to 14 days. You have to fly after the 10 to 14 days. If you have a PCA done or PCI done, percutaneous angiogram, after 5 days, you can fly. If you have a stroke, which advised to wait 10 days following event, if you're very stable, you can even carry it out within 3 days or 72 hours of the event. So very important points. All these things you have no other option to have to remember before the exams. If you go to the respiratory systems, you in case of pneumonia, it should be clinically improved. This is more controversial and most important that the patient is having pneumothorax, whether it's a spontaneous pneumothorax or patient have a complicated pneumothorax, you have the absolute contraindication to fly. But if you have a drainage done after 2 weeks, if there is no residual air in the chest X-ray, you can fly. Still, there are some controversy between the British Thoracic Society and as well as the the guidelines currently coming, but they were recommended that not to fly with up to 6 weeks. But recently they have changed the guideline and making that you can fly after 1 week of post check X-ray. So please remember these points because they will be keep asking these changes from questions. So now we can fly after 1 week of post check X-ray, equally important. And now here come the pregnancy. They will, if pregnancy is more than 36 weeks, you are not supposed to fly. And after 32 weeks with multiple pregnancy, they will be not allowed to fly. And if you are flying after 20 weeks, they will need to have a NORM certificate from a registered physician to have whether you can fly or not. So this is the part which is multiple times asked basically in the part 1, and you have to remember all those things, no other options. Now there is a lot of questions. Basically, this is come in part 1, and this is very easy. You have been studying in your second professional MBBS days that what all the medication you should not practice in given in the pregnancy. There are a lot of guidelines there. There are a lot of drugs is there which can be given, which cautions, which cannot be given. So here we are going to tell you basic drugs which has multiple times asked in questions in different groups to just to remember. Rest of the things there are a lot of we cannot discuss here. So the tetracycline, aminoglycosate, sulfonamides, trimethoprim, and quinolones are completely avoided in the patients in a pregnant lady. Another drug like AC inhibitor, ARBs, statin, warfarin, sulfonylurea, retinoids, and all cytotoxic drugs are completely avoided during pregnancy. Please remember, like that way, majority of anti-epileptic drugs like valproate, phenytoin, carbamazepine are potential harmful, and however, you have to balance a sensible balance. So, but this AEDs or anti-epileptic drugs, we will discuss in the end of the topic, like how to prescribe anti-epileptic drug in a pregnant lady. But for timing, you remember this that the drug should be avoided in a pregnancy. So keeping that in mind, we'll move to the next topic, the GI topic, like that. This is equally important, and let's see how you're going to treat with this kind of patients. So this 28 years old, 32 weeks pregnant lady come with intense itching, particularly her palm, soles, her liver function test is showing ALT little bit high, bilirubin level, but there is no signs of liver failure. What are the most common appropriate management and key complication to monitor for this? So if you understand, can anybody tell that what it is? Yes? Okay. We'll discuss as time comes. Okay. The next question is that this is 34 years week, pregnant 30 years lady, admitted with nausea, vomiting, abdominal pain, is hypoglycemic, her liver enzymes are showing ALT of 720. So what is the most crucial management step? Differentiate between acute liver, fatty liver of pregnancy or ICP. So supportive care. This is you are supposed to answer. 35 weeks of gestation, 32 years lady, upper quadrant pain, nausea, blood pressure is 160, 110, lab showing hemolysis, elevated liver enzyme, thrombocytopenia. What is the most likely condition and how do you manage
HELP
these patients and what diagnosis?
HELP syndrome.
I was expecting
HELP
that
syndrome.
because yes, yes, yes. This is what people will always answer, but you have to know the other points only. Let's see what happened. So that first question was there for intrahepatic ICP, not in intracranial pressure. It is intrahepatic cholestasis of pregnancy, also known as the obstetric cholestasis. Very important point. You have to keep it in mind, and this is not very uncommon. Almost 1% of pregnancy will have this kind of issues, particularly given in the last trimester or third trimester. And this is the one of the most common liver disease which patients encounter in pregnancy. And if you are worried, this is the most common reference as a medical consultant you will get. We used to get it in the maternal medicine department from in UK as well as in India. So this please remember like that. What is the features? Like a pruritus of most commonly in the palm and the soles usually will happen. There will be no rashes. Please remember this point. There will be no rashes, but there will be some skin changes will be there because of the continuous scratching. And there will be raised bilirubin. How do you manage it? Very simple. Mostly conservative management. Ursodeoxycholic acid used to make symptomatic relief. Weekly liver function test you have to do, and maybe after 37 weeks you have to induce the liver. Why? This is one most common point you have to do. ICP sometimes increase the rate of stillbirth, and it is also is one of the quality indicator, but it's not generally associated with the maternal mortality. So it is not harmful for the mother, but it's maybe harmful for the baby, and that's why we have to be very careful about it. So this is one point. Now next we move to the next of it, acute fatty liver of pregnancy. This is most rare and most common in exam. So it is more rare complications, but with the exam, the MRCP has a pattern. They will ask you question of the rarest complication so that you will be aware of it. So this is most rare in real life, but most common in exam. So basically, all this problem basically seen this in third trimester or even immediately after following the delivery. Again, important point. Please remember, don't get confused if they ask you similar kind of picture and it's happening after the delivery. So you have to remember its mind. What are the symptoms? Abdominal pain, nausea, vomiting, headache, jaundice, hypoglycemia, and sometimes it's having preeclampsia, very non-specific. The ALT usually elevated up to 500, and the management is simple, like supportive care. And once the diagnosis delivered confirmed, you have to deliver the patient based on the patient's gestational age. So acute fatty liver of pregnancy, you will get definitely questions, and this is very common in part 1. So be ready for that. One points I wanted to highlight you, and you will get different questions, that all this Gilbert syndrome and Joubin-Johnson syndrome are get exaggerated in the pregnancy, in a pregnant lady. So please remember. Now comes most commonly encountered in exam and most commonly discussed among the students and the trainees is HELP syndrome. That is the hemolysis, elevated liver enzyme, and low platelet cell.